Good afternoon, and it's pretty intimidating to be here towards the end of the day. I started off in the morning, and I'm ending in the evening as well. So the title was a little perplexing because I was trying to fit in my thoughts about sodium disorders. So, and I'm not going to do the talking, you're going to do the talking. So I'm going to present you cases, and I can see at least one person in the audience who knows all these cases. Dr. Riddhi, you're sitting there. You're not supposed to answer, you're not supposed to give tips. Thank you. So we'll move on to this. You have a remote? Yeah, thanks. This one. Yeah, thanks. Okay, so here is a 24-year-old lady married for 2 years, no offspring, presented with history of polyuria and polydipsia over 2 months, had diarrhea and increased weakness for 4 days. There's history of primary infertility. Evaluation outside revealed a prolactin of 40. Someone had started her on cabergoline for that 40 and stopped it in 2 weeks' time. And she had menstruation once in 3 months. She had already been started on desmopressin 0.1 milligram at bedtime, and her symptoms were improving. No weight loss. On examination of fundus normal, systemic examination was normal. So I'm going to ask you one question straight away. What is polyuria? What's your definition of polyuria? One of the things which we hate getting asked in exams is definitions. Is that right? In the Indian system, they love asking definitions. I guess I'm not like that, but I'm going to ask you questions. What is polyuria? More than what output, more than how much is polyuria? 3 liters. Is that enough? Okay, fine. So it's a very relative thing. So I'm going to ask you to go and do that as homework and look up per kg, per kilogram, how many ml, but I'm not going to give you that answer because it's rote knowledge. I don't think it's necessary over here, right? So you got this history over here. Can you give me several possibilities? We need to move fast. I have something like 4 or 5 cases, so I want to finish with them all now. Give me some differential diagnosis. You can speak up, okay? I will never come as your examiner to Sri Lanka, so you don't need to worry. Thank you. Okay, I'm going to pass the mic around. Young lady, would you like to answer?
Diabetes insipidus.
Diabetes insipidus.
Cranial.
So because of the diagnosis of polyuria and polydipsia, you think it's diabetes insipidus. And because someone has started on desmopressin, you think it's diabetes insipidus. Possibly. Okay, anything else you'd like to say? Putting all this information together. Prolactin of 40 nanogram per deciliter. I'm sorry, you use the other units over here? All right, we are oriented towards that. Dr. Riddhi, can you make these conversions? You're thinking of going to the UK, so you better do these conversions fast. 40 nanograms, okay, the normal in this lab is up to 25. This is 40. So do you think that's, what do you think? What do you make of that? Where would you get these 40s?
Sorry?
This 40, what is the relevance of 40? Is it relevant or is it not relevant? It is. I beg to differ. I would say in most situations not. You stick a needle into someone's veins and they're under stress, the prolactin can go up. It's very mild, all right? If you want to think of it as an organic thing, there is something called stalk compression, right? So if you have something that is sitting there and going into the supracellular area, it could rise. But even that, 40 is not impressive, all right? Do you know of any common condition where you can get mild elevations of prolactin? Common condition. Hypothyroidism, yes, okay. So hypothyroidism, primary hypothyroidism is a common condition where prolactin can be. Borderline prolactin values can be seen in polycystic ovarian syndrome. So that's another condition which you should think about. Common cause for irregular periods once in 3 months could very well be polycystic ovarian syndrome. 18-year-old, oh sorry, what's her age again? 24-year-old with recurrent thirst, okay? What are the multiple things she's thinking about at the age of 24? I want a job. I need to get married. But she's not thinking about marriage, her parents are thinking about it. So all these factors are also stress. So you could be drinking a lot of water What is that called? Psychogenic polydipsia. Well, it could be diabetes insipidus. Let's say that the physician who started treatment is a sound person, did the right tests. Okay, right, we'll go on. What do you want to do next? Tell me what you'd like to do.
Urine osmolality.
Urine osmolality. Okay. So this patient is on treatment and you're going to do a urine osmolality. I don't have any investigations on her. Let's say that she's lost her file. Or she wanted to get a second opinion and she didn't show me her file. She wanted to see how smart I was.
The investigation would be blood sugar.
Okay, I would do a blood sugar. I've ruled out diabetes. Glucose has been done. That's normal. This is not diabetes mellitus. I'm telling you that right away. Okay, 24-year-old lady, BMI of 21.5, waist circumference 80 centimeters. She's not at risk. Okay, right. Okay, let's go a little beyond that. This is not diabetes mellitus. Let's look at central causes or peripheral causes. Remember the title of the session is sodium. So it's not glucose, right? Okay, so I want to revalidate what they found outside. I'm going to check her electrolytes. If you're sitting in a primary care center, which test is almost always borderline elevated or elevated in diabetes insipidus? In a primary care center? Sodium. So I've done the sodium. I've done the potassium. Well, is the potassium relevant? Is potassium relevant for polyuria in any way? Why? Tell me, who said yes? Hypokalemia. So, chronic hypokalemia can cause nephrogenic diabetes. It can cause damage to the tubules and cause nephrogenic diabetes. Okay, potassium normal, sodium 143. Thank goodness millimoles and milliequivalents are the same. 143, upper limit of normal, close to, okay. Bicarbonate 29, right. Right, now we're thinking of a possibility of a central cause. You got the thyroid functions, they're normal. TSH is okay, looks a bit suppressed, but anyway. FSH is normal, LH is 10. So do you think this is a anterior pituitary problem, looking at all this? Is it or is it not? It is not an anterior pituitary problem, right? And her irregular periods or cycles might be due to? Yeah, very much. So stress, anything else? Polycystic ovarian syndrome, yep. Cortisol 18. So this is not an anterior pituitary dysfunction. A1C 5%. You said polycystic ovarian syndrome, looking for insulin resistance, glucose is normal, A1C normal. What next? You would like to prove the diagnosis. Otherwise, if she has diabetes, central diabetes insipidus, she has to take treatment for most situations, life, yes? All right. Oh, can we have these beautiful lights off? We can have these lights for our dance in the evening, but we should put them off right now. Thank you. Can't see the slide properly. Uncle, can we have the lights off? Yeah. One more, possible. Okay, can we see this? It's not clear. Right. Oops. How do you get this backwards now? Right. Okay, we'll try and figure it out now. Sorry. All right. Now when you have someone with polyuria, what do you look for? You look for the pituitary. And what do you look at in the pituitary? You look for the bright spot. If the bright spot is absent, it favors central diabetes insipidus. By and large, it's not 100%. There can be false positives in 10%. There could be false positives in 15 or 20%, but it can. The second thing which I overheard you saying, what does it do? If you do not have a bright spot, which is not there, it strongly favors a possibility of diabetes insipidus. It also rules out something else. Something else. Remember the stressful lady, the marriage, the job, everything coming in, it rules out primary polydipsia as a possibility, right? What else do you look for over here? Thank you. What else would you look for over here? The stalk, right? What do you think about the stalk? It's thick. It's a thickened stalk, right? All right? It's definitely more than 2 to 3 millimeters. It's quite thick, all right? And what else do you see over there? The pituitary is bulky, right? There's something called Elster's staging of the pituitary gland, which is probably better seen. Okay, so anyway, you have loss of T1 hyperintensity, thickened stalk, bulky pituitary. This is pathology. There is a problem that we are dealing with. This is probably central diabetes insipidus from the MRI. But I want to prove it physiologically, okay? I'm not the kind of guy who goes around doing an MRI and everyone who has an headache or sneezes in front of me. Are you? No, right. There are people who do that. So I want to prove it physiologically. So what do? I stop the medication and see what happens. Coming back, this is in this particular coronal cut, you can see that the pituitary is rounded, and I was talking about staging of the MRI. There's something called Elster's staging, right? Any radiologists here? Okay, then I can pontificate. You know what that means, right? So, Elster's staging means you can have a concave pituitary there, and that's 1, and then it's 2, becomes flat, 3, it becomes convex, 4, it becomes almost spherical. You know, this doesn't show a distinctive pathology anywhere. I would say it's probably a 3, okay? That's what it looks like. And when you have spherical ones, it means hyperplasia, or it means infiltrative disease. Very definitely infiltrative disease or hyperplasia. Primary hypothyroidism, you can get a spherical pituitary, all right? People who are taking estrogens in excessive quantity for whatever reason, or on HRT inappropriately, may have a spherical pituitary. Infiltrative disorders, which I will not talk about right now, can cause that. So stalk thickening, bulky pituitary, all seen here. Nodular thickening, bulky enlarged pituitary, not enhancing with contrast. Okay? I presume that even though physically I'm young, that your eyes are younger than mine. And you can see in the corner it says contrast positive. There's no contrast uptake, but you can see the contrast there, right? Below, you can see the contrast. So this patient has no contrast uptake here. What does that rule out? It rules out several things. Okay, I need to move on. Water deprivation, sodium within 8 to 10 hours has gone up to 156. After desmopressin, sodium fell to 144 in 2 hours. Yes? What is this? Central diabetes insipidus. If it was negative, then it makes life pretty difficult. But we'll talk about that later. So what is your differential diagnosis? Come, 1, 2, 3, 4, 5. Differentials. I am not your examiner in the Sri Lankan College of Medicine as yet, or probably never. So you can answer this question. Right? Infiltrative disorder. Give me some examples. Yes? A lesion in the pituitary. So which lesion? What condition can you think about? Common conditions. The stalk is thickened fully. Yeah. There is something infiltrating the stalk and the pituitary. Give me some differential diagnosis. No, there's no craniopharyngioma here. Well, it's a whole different cup of tea and a kettle of fish. This is not a craniopharyngioma. So, sarcoidosis, right? So you've seen sarcoidosis. Come on, give me some more differentials. Okay. We're running out of time. So we know it is central DI. Rule out sarcoidosis. Great minds think alike. Fools seldom differ. Try and figure out which one you are. And me. Right. Lymphocytic hypophysitis. You've seen this? Okay, heard of it? Seen it? You will. I'm sure you're seeing it because, well, we come to why you're not. Why? How do you prove you have lymphocytic hypophysitis? Lymphoma? Possibility? You tell me why it is and why it isn't. Okay. Early days. There is no leptomeningeal involvement. What does that mean? There is no contrast uptake. You saw that MRI, go back and think, there was nothing over there. Leptomeningeal involvement occurs in very, not just localized, but involvement of the meninges. And these conditions are what? Sarcoid, then tuberculosis, then carcinomatous meningitis, right? These are possibilities. Other infiltrative disorders can also come there, but these are some of the common ones. Okay, even lymphomas for that matter can, but much less commonly can happen. No systemic symptoms. So, when there's no systemic symptoms, you should rule out certain conditions. For example, sarcoid can be localized, but sarcoid very often can have a lot of systemic symptoms. By the way, the chest X-ray was normal. All right? There's no lambda sign. What is lambda sign? Right paratracheal lymph node enlargement with lymph nodes on both sides in the mediastinum. So it looks like a lambda, right? So there's nothing there. To make good measure if you want to go further. But then before you go further, what else should you do? So what's next? What are the tests you'd like to do? No arthritis, no skin lesions, no lupus pernio, what blah blah. Go on. Okay, so here's our comprehensive differential diagnosis. Lymphocytic hypophysitis, the most common form of pituitary inflammation, it's quite common. Could be happening in the late pregnancy or postpartum period, but can happen even otherwise. So it's not that rare. It's quite common. Granulomatous. So we talked about sarcoidosis. Could be vaginas. Tuberculosis. You have seen, you still have tuberculosis as a problem in Sri Lanka. Yes? Or have you reached those high public health levels even in tuberculosis? You have eradicated malaria, you have done a lot of great things. But tuberculosis is there. You have seen TB, meningitis, you have done MRIs of the brain and you see how they are. There is no leptomeningeal involvement. Much less likely to have a localized tuberculoma in the pituitary. Can happen. Happened, but much less likely. Plasmacytic hypocystitis, Ig4 associated disease. Heard of this? Seen it? Very important to think about. I want to highlight two things here particularly. Lymphocytic hypocystitis and plasmacytic hypo, because increasingly these conditions are very important. But once again, number 3 is associated with systemic disease in almost 85% of patients. Isolated pituitary disease is much less likely. Much less likely, but it's always possible. Okay, so looking at all that, bone scan negative, right? ANCA negative because vaginous, but there was no nasal involvement, no lung involvement. ESR, CRP, all okay. ACE levels normal, some 15 or 16. IG4 levels normal, complement normal. We'll talk about IgG4 a little later, but it's all negative. Bone marrow trephine, normal. We want to be dead sure. ACE levels can sometimes be negative, all right? We want to be really sure, so we did that. We are worried, we want to be really sure. CSS lymphoma, possibility, I'm not going to go and biopsy a stalk. I will cause more damage. This pretty lady has normal thyroid functions, normal cortisols. So I'm not going to go and damage her pituitary, okay? So I'm leaving it as it is, and I'm going to say, this is possibly, what is it? This is lymphocytic hypophysitis. Anyone wants to disagree with me? You're welcome. That's what this forum is all about. Yeah? Possibility of lymphocyte. So by and large, well, I went on leave and my colleague started on prednisolone 0.5 mg. We all have different philosophies. I'm not saying he's wrong. I'm not saying I'm right. I wouldn't have started it. Because there is not much evidence. But we don't know, no one has done randomized controlled trials and nobody will ever do in these diseases. So it may help. We don't know, we can't prove. And we continue the DVAP for life. Okay? Are you satisfied with this diagnosis? Do you have any other alternatives? How we handle this patient? Right? This is common. Has to be one of the commoner causes of pituitary inflammatory disease. Case number 2. 35-year-old lady, history of recurrent facial palsy for 1 year, polyuria, polydipsia 1 year, diagnosed with central DI, started on desmopressin nasal spray, had 2 months of steroid glucocorticoids 1 year back with resolution of symptoms and recurrence after stopping. Okay. Same differential diagnosis come into play again. Examination, left facial palsy, clinically unremarkable, intake less than output 5/8 on stopping desmopressin. Clearly, clinically she probably has diabetes insipidus. Facial palsy with diabetes insipidus, what should you think about? Sarcoidosis. But you should always have a differential diagnosis. So inflammatory sarcoidosis is a possibility, right? So what's your differential diagnosis? Other infiltrative disorders. Is there any other infiltrative disorder which can involve the pituitary and involve the facial nerve? Systemic disease involving pituitary and facial nerve. Which one? Hemochromatosis, does it cause facial nerve involvement? I've not seen it. I don't think so. Why should it? It won't. Okay. That's a normal chest X-ray. And fine. Sarcoidosis coming up or going away. I'm not saying chest X-rays have to be pathological in all sarcoid. That's the MRI. What does it show? Now when I press this thing, the slides change. So basically, if you look at the center, there's a slightly darker area. It's more bulky towards the right than the left hand side. What next? You've already gone through the exercise, you know what to do. Okay, ACE level 17, LDH 512, bone scan negative. Why am I doing bone scans, by the way? What am I trying to rule out? Another infiltrative disorder where you can get aches and pains, lytic lesions in the bone. Histiocytosis, yeah. Histiocytosis, your old, what is it otherwise called? Histiocytosis X is the old name. What's the new name? Langerhans cell? Right. So, sarcoidosis less likely. What next? ANA positive, complement 80%, right? dsDNA negative, ANCA mildly elevated, see ANCA. No, nose is normal, lungs are normal. ACE level 17, okay, we've gone through that. What have we ruled out here? Huh? Which one? Viginous. It's borderline high actually. Well, clinically it's not viginous. They're more florid. If they're going to go right into the cellar, they need to have really florid nasopharyngeal involvement. Okay, here's the magic one. IgG4 positive. Useful test. There's one place in Sri Lanka which does it. Anywhere? Please get it done. Okay, because it's increasingly so important. It's a medical disorder, IgG4 disease. Not just an endocrine disorder. It is so very common, being picked up all over the place. So all this is basically suggesting, and I have a biochemical test once again to show the diagnosis. No biopsy as yet. Is there anything unusual about this case? Anyone knows much about IgG4 disease? A little bit? It's a systemic disease. You can come with fibrous mastitis. Okay? You can come with lung fibrosis. You can come with retroperitoneal fibrosis. Virtually any organ in the body can be present. So it's usually systemic. In 85%, it's a systemic disease. This patient does not have systemic disease. That's what goes against it. but the titers are classical. They are diagnostic of very, very high. You don't get values more than 1500 or so as false positives. It's very high. So, we started on methylprednisolone, followed by deflazacort. We also gave pulse dose cyclophosphamide, and we continued desmopressin. Patient felt better, physical sense of well-being. These are the options available. But let me just point out and say, the expensive ones at the bottom, there is no evidence base yet. Unless you want to try out something fancy, but we really don't know if they help at all. I would probably advise against rituximab at all. So, no randomized trials. Principles, glucocorticoids is the first line of treatment, and then some other immunosuppressants can be used. Okay, look at the MRI. There is definitely an improvement in a year's time. You need to follow these people up for life. You may need to image some parts of the body depending where it's involved. I won't do an MRI every year over here. I'll just check her visual fields, check her pituitary functions every year. Maybe I'll do an MRI once in 3 to 4 years. That's what I do. IgG4 levels have plummeted, come down very low. Case 3. 40-year-old came with facial puffiness, decreased appetite, general weakness, sporadic fever for 3 to 4 days, loose stools. Gave birth at home, sorry. Didn't give home at birth, but gave birth at home, right. Followed by 10 days of postpartum bleeding and managed at home. This is an Asian disease. Sheehan's syndrome. But with your fantastic primary health care that you have in Sri Lanka, you don't see it anymore. Yes, am I right? You don't. Okay, I'm sure you don't, right. It used to be common in the past. It's dwindling. Maybe in remote areas it must be happening. So, and therefore, persistent amenorrhea, all of you know this, Sheehan syndrome, right? Okay. Investigations done long time back, 16 years. Sodium 115, potassium 5, bicarbonate 20, hyponatremia, you know it's Sheehan's. Thyroid functions, total T4 4, normal is 5 to 12. FTC, free thyroid, 0.8 to 2 in my lab. Cortisol, 0.7, very, very low, all right. ATM cortisol should be hopefully more than 8 or 10. And FSH is also very low. Pan-hypopituitarism, right. Diagnosed with Sheehan's, started on glucocorticoids, thyroxine, improved, went home. 10 years later, she presented with polyuria and polydipsia. You know, we always have this 10 years later, 20 years later. In South Asia, it's 4 years later. You know, what does everyone hope for in South Asia 4 years later? What is it? Tell me, give me the answer. This is not endocrinology. 4 years later, what's going to happen? You'll win the World Cup in cricket. Okay. Didn't happen for any of us this year, and that's really sad. Okay. Right. Okay, anyway. 10 years later, she presented with polyuria and polydipsia. Sodium 131, urine spot sodium 9, 141, potassium 3.7, overnight fast. What does this tell you? What does this tell you? What is it or what is it not? What is it? So, serum sodium is 141, potassium 3.7, 12 hours fast, no water intake, not yet hyponatremic, unlikely to be diabetes insipidus. Now tell me, how many times have you seen Sheehan's with central diabetes insipidus? It's rare, it's very unusual. It can happen in the acute phase. Suppose you have a very bad acute Sheehan's where the whole pituitary just swells up and presses on the hypothalamus, it can happen. But that is generally lethal, okay? Or if it's in snake bites. Snake bite induced hypopituitarism, yes, Sri Lanka? You have it? Heard about it? No? Bangladesh? No one from Bangladesh? Pakistan? No snakes in Pakistan? Okay, right. So, it is seen. We see it in these very wet places in India, lots of coconut trees and all that. It's quite common. Anyway, that type can have DI, diabetes insipidus, but even there it's not that common, right? Osmolality 330 millimoles per liter. They anyway decided to give vasopressin. It went up to 507. It's okay. Right. We're not here or there. It's gone up. It's not really giving me a diagnosis. Sodium 142. From 141 it's gone to 142. It's not come down, right? So this is not central diabetes insipidus. Diagnosis of primary polydipsia. Rule out a hypothalamic dysfunction. Rule out a psychiatric disorder. See, this lady, poor thing, has had postpartum hemorrhage, obviously might be stressed out, family issues, one child, taking the burden of everything at home, and so there is an issue over here. But we need to rule out these possibilities. Is there a primary psychiatric disorder? You can have primary polydipsia without a psychiatric disorder, but rule out depression, schizophrenia, something else which may be sitting over there making them drink a lot of water. So we need to be sure there's nothing structural, because primary polydipsia can be due to hypothalamic dysfunction. We said Sheehan's, right? Clinical diagnosis is correct. But we never did an MRI in 2003 because we were so sure of the diagnosis. So that's the MRI brain, and what does it show? Okay, it's written there at the bottom. Partially empty sella, thinned out pituitary gland, compressed posterior inferiorly. So it's an empty sella which is in favor of Sheehan syndrome. There is no supracellular mass sitting over there. You can see the optic chiasm actually going in a V downwards over there. Okay, primary polydipsia. How do you treat it? How do you treat it? You don't like old men who have grey hair and beards? Say so. Okay. Right. How do you treat this condition? Behavioral treatment. Okay, they need a lot of tender, loving care. Someone needs to sit with them, spend time with them, counsel them, and counsel them. And then wean them off this excessive water drinking process, find out if there's something else going on. That's it, nothing else. Can this be dangerous? Can primary polydipsia be dangerous? Can it be damaging to the body? Yes or no? Yes, how? Okay, so they drink a lot of water and they may damage the renal tubules and they may develop a nephrogenic diabetes insipidus. They could have concomitant nephrogenic diabetes insipidus with salt wasting, but that generally doesn't happen in younger people. It happens in older people. So they say a young person, please don't do this. I've hit 7 or 8 in a day, but they say a young person may take 20 liters of water and nothing might happen. Heaven's sake, don't even try doing it. But that's what the textbook says at times. Don't do it. Right? Boy, sometimes professor says something and you all go and follow it. Right? Thank you. 68-year-old lady developed generalized aches and pains, was on antihypertensives, normal dietary intake. Because of the aches and pains, they did an ESR, it's 110. Calcium, phosphorus, normal, creatinine, blah, blah. Look at those investigations. Tell me if there's anything wrong over there. I figured out why you guys say sarcoidosis for everything. You know why? Because it's a sarc meeting. Okay, right. Okay. Okay, tell me, what do you see? Anybody? High ASR, yes. Anything else? Huh? What is that? Total protein is high. Albumin is low or normal? 4 is normal, right? In your language and mine? Normal? As in, whether using SI units or not, that's what I meant. So therefore globulins are high. Sodium 131, potassium 4, urine spot sodium 12. What is it? Dietary intake is normal, by the way. Dietary sodium intake, she takes about 8 to 9 grams of sodium per day in her diet. All that is fine. Nothing. 131 sodium, why? Pseudo hyponatremia. What is pseudo hyponatremia? Why does it happen? Any biochemists over here? I'm looking for one hand which might go up. Pretest possibility of a biochemist in this room is P less than 0.001. Right? Okay. Now you need to go and read that up because it's important. This is missed out. Because I talked to my biochemist before I came here. She said, we never see this condition. I said, madam, you don't see this condition because you don't look for it. All right? So with all our high technology, we cannot avoid this. They cause borderline hyponatremia, which is not lethal, and probably people don't worry about it too much. That's why. Okay? The old method, so you basically are using what is called indirect potentiometry and not direct potentiometry. With indirect potentiometry, you cannot avoid pseudohyponatremia. It can happen. But you can have dual causes for hyponatremia in the same patient. So that's where you need to be worried and you need to correct for the low sodium. Okay, M-band positive on electrophoresis. What is it? Diagnosis, multiple myeloma. Right, good. Okay, that's a biopsy. The marrow which shows 51% plasma cells. Patient was started on appropriate treatment. Bortezomib. Nowadays we just need to remember the first part of all these words because the second part is all the same. So he was given bortezo and cyclophosphamide and dexamethasone besides 3 doses of zoledronic acid for treating myeloma. After chemotherapy, developed multiple episodes of large volume watery diarrhea associated with recurrent vomiting, developed facial puffiness, had postural dizziness and multiple falls at home, had 5 episodes, blood pressure 100/60, postural drop 90/50. What is your differential diagnosis? Because this is a real life case. It is a real life case. You have to know how to sort it out. It's not exotic. Okay. Someone was cursing me and saying, why is this guy talking about IgG4 disease? But that's because it's not rare. So anyway, this is definitely not rare. You've all seen myeloma. What is it? Okay. Biochemistry shows sodium 122, potassium 2.7, bicarbonate 12, chloride 105, magnesium 1.36, phosphate 1. Okay, let me tell you, phosphate is low, magnesium is low, sodium and potassium you know anyway. Albumin 3.8, globulin 3.9, urine spot sodium 22. So just describe what you're seeing. What is the biochemical anomaly you're seeing? There is hyponatremia. Is there loss of sodium in the urine? Yes, it's inappropriate. 22 may not be very high, but it is inappropriate for the low sodium. So there is natriuresis. What else is anomalous over here? Hypomagnesemia is there. Bicarbonate is low. So what does that tell you? It is acidosis is there, possibly. I have not given the full arterial blood gas, but anyway, let's say it's metabolic. Potassium is low. Now, how do you put all this together? What condition are we dealing with? Renal tubular acidosis, right? I heard it. Type 1 RTA, and presuming you're not an orthopedic surgeon, it's not a road traffic accident. All right? So, renal tubular acidosis, type 1 or 2? Myeloma is associated with glycosuria, aminoaciduria, that is proximal renal tubular acidosis. Type 2. Okay, so type 2 renal tubular acidosis. Maybe. Okay, folks, the show is not over. There's more to this. Right. So, what are the possibilities? Can you think of more things? It's having vomiting, right? Did I say vomiting and diarrhea? So it may be depletional. Sodium can drop, potassium can drop. But remember the drugs, the medications. Bortezomib, cyclophosphamide, dexamethasone. Now what should you think about? Come. Anyone's worked in oncology here? I mean, all of you go, right? When you're doing your internal medicine, you work in, you treat patients with cancer, you use cyclophosphamide. What do you look for? Yes? Vomiting? Yes? That is depletional. Anything else which you can think about cyclophosphamide? Huh?
Cystitis, secondary cycle.
Cyclophosphamide induced cystitis. I mean, that can't explain the electrolyte disorders here, can it? Okay, so it can cause other things. So, could this be pseudo hyponatremia? Yes or no? Do you remember what the biochemical values are? I don't know how to turn the slides back, that's why I'm asking you. Do you remember what the biochemical values are? Right? When your boss comes and rounds at 9 a.m. in the morning, you need to know all the electrolyte values, all the counts, everything on rounds. And you can't answer this one question, which I set a slide with you 10 minutes back and you can't remember. Okay, right. So, pseudo hyponatremia, right? Unlikely, because the globulins had actually come down to normal. I don't know if you noticed that, right? Renal tubular dysfunction, highly likely. It's got all the features of renal tubular dysfunction. SIADH, why I'm asking this question is cyclophosphamide can cause SIADH, maybe centrally, and cyclophosphamide can behave like a pseudo ADH on the renal tubules and cause that. Very difficult to prove in a dehydrated patient. Very difficult. You need to rehydrate and then wait for things to happen. You cannot prove it over here. Very difficult. So don't think about it. It's not important. There are more pressing things to worry about than SIADH. Even though that's the internist's favorite diagnosis. When you don't know the answer, you say SIADH. Right. So please avoid it as far as possible. Hypocortisolemia, is it possible? All of you are endocrinologists. So, right? Is it possible? They gave dexamethasone. How long do you give dexamethasone when you treat myeloma? Not too long, 2 weeks, recurrent cycles. But what kind of doses do you give? You throw the kitchen sink on the patient. You give 40 milligrams of dexamethasone, big doses, and that can potentially cause a problem. It is not recognized. In fact, we started figuring it out with our hematology patients, and we were wondering, and we used to actually follow these patients up. They had weak HPA axes as well. So, had postural hypotension, we did everything possible. We started replacing sodium, potassium, a bit of magnesium as well. The bicarb wasn't too bad, so we didn't worry about it. And lots of salt in addition. We started on hydrocortisone. So biochemistry, this is what we saw. Oral potassium bicarbonate, cortisol was 4, and this is about 3 weeks after the last dose of dexamethasone. So there's something which is not right. And we started replacing steroids, glucocorticoids, we gave prednisolone, and we followed up the patient and stopped the prednisolone after 3 months. Temporary HPA depletion. Okay, so that's basically, this patient had multiple things at the same time. Not multiple myeloma alone, but multiple reasons for hyponatremia. If the hyponatremia continued for a long time, in spite of normalization of the myeloma parameters, I should also rule out cyclophosphamide induced tubular toxicity, which might cause a long-term salt wasting. That can also happen. Case number 5, okay, this is a spotter. I know time is running out. 11 minutes and 3 seconds left. Right. 65-year-old gentleman presented with hyponatremia and altered sensorium. Sodium 118, other analytes normal. Urine spot sodium 34, random cortisol 19 microgram per deciliter. What are the possibilities? This patient is 65-year-old. I'm not going to give you too much history because that will give the clue. But he's 65 years old and he has a normal salt diet. You know, you should take this history, very important. How much salt are you taking? Because half the hypertensives in the world are taking far too less salt. All right? Low salt diet, and they'll make it really low, subterranean low. So the patient was taking normal salt, not in any other medications, no ACE inhibitors, ARBs, very important causes for hyponatremia, by the way, you know that. So, what else? What are the possibilities? Look at the shape of this thingy in the sella turcica. What does it look like to you? Huh?
Bleeding in that area.
This is a chronic history. Very chronic. Not quite subacute. It's going on for a couple of weeks. Patient's been feeling unwell in some ways, eating well, but altered sensorium. No headaches. No headaches. Okay? So it's a GADO positive scan. And what is the shape of this thing? You know, a bleed, when it goes up, it takes a uniform shape. Either it bleeds into the pituitary, you get one really big apoplexy, it will just go up like that and it will be nice and smooth. Okay? It's an irregular shape thing. When you see things like this in a 65-year-old man with hyponatremia and normal, in spite of such a huge lesion, which means that the anterior hypophysis is not significantly affected, cortisol being normal, thyroid functions were normal, and hyponatremia. What's the favorite diagnosis? Sorry. No ACTH deficiency. Cortisol is 19 microgram per deciliter. So, what's the favorite diagnosis an internist makes in Sri Lanka when he goes on rounds and he doesn't know the diagnosis? SIADH. For once you're correct. Okay? This man was a heavy smoker. All right? And he had a tiny little patch in the lung, small. It was half a centimeter size. It is a CT and it showed more lymphatic involvement. And this is a metastatic lesion in the pituitary gland. Okay. It's a difficult one. But actually I've come to Sri Lanka before and I've given a talk with this slide. So maybe even if you didn't know, you might have seen. So that's part of the story. Okay then, shall we say bye for now?